Bismillah ar-Rahman ar-Rahim. On behalf of my co-moderator and the entire team at the Emirates Cardiac Society, I would like to welcome you, ladies and gentlemen, to this month's multimodality rounds brought to you by the Imaging Working Group of Emirates Cardiac Society. My name is Firas Al-Badareen. I'm a cardiac imager at Cleveland Clinic, Abu Dhabi, and I am the head of the Imaging Working Group of Emirates Cardiac Society. It gives me a great pleasure to host tonight's session with my colleague, Dr. Juwairiya Al-Ali, who's an avid cardiac imager at the level of the United Arab Emirates and the entire region, and is also the president of the Emirates Cardiac Society. Dr. Juwairiya.
Thank you, Dr. Firas, for the kind introduction. This academic activity is actually one of my favorite for Emirates Cardiac Society. We have been running this for a while, and Dr. Firas have been doing an excellent job creating a very interesting program for everybody. And I would really like to thank all the speakers who are presenting today for this important topic. And I would like to thank all the attendees who are here. And I would like to encourage you to post your questions in the chat so we can get to them. We'd like to have this session to be very interactive. So don't be shy, ask the question. There's no small question. And this session is not only for imagers, so this is for all cardiologists. And as you know, you joined because you know the topic. The topic is very relevant to all levels of cardiology because you see this in your practice and you always have questions about this. Whether this investigation is enough, you need to do another investigation, what added benefit would be from having other imaging modality. So hopefully our speakers are going to answer all these questions for you tonight. So I'll hand it back to Dr. Firas to present the program and present the first speaker.
Thank you so much, Dr. Juwairiya. I would like to second her interest in this clinically relevant topic. And we really have a special treat for tonight. The topic we will be discussing, which is improving diagnosis of prosthetic valve endocarditis and other cardiac device infection, is very relevant clinically. What we will try is to place enough emphasis on the clinical aspects of the disease as well as the role of multimodality imaging in guiding management and diagnosis. For this, we have aligned a stellar lineup of speakers that we will be introducing in sequence. And it's not all, you don't have two professional society presidents joining you in a session every month. We are very fortunate tonight to have Dr. Muad Al-Mallah as a keynote guest. Dr. Al-Mallah is a professor of cardiology at Methodist Research Institute and is the director of cardiac PET at Houston Methodist Hospital. And he's the current president of the American Society of Nuclear Cardiology. Dr. Mallah is a luminary in nuclear cardiology and is no stranger to the region. He had his touch in advancing the field of imaging back in the day when he used to practice in the region several years ago. So we will have, as just an overview of tonight's agenda, we'll have two presentations. Then we'll open it up for a live discussion. Please feel free to join us in this discussion and send in your questions. We'll try to cover the nuts and bolts of the various imaging modalities that we will be discussing. So your participation is very important. Without further ado, we'll kick this off with my friend and colleague, Dr. Mohammed Khalil, who's the section head of clinical cardiology at Cleveland Clinic, Abu Dhabi, who will be discussing the role of echocardiography in diagnosing prosthetic valve endocarditis. Dr. Khalil.
Thank you, Firas, for your kind introduction, and good evening, everyone. Let me start by sharing my screen. Let me see. Do you see my screen? Can you see my screen, Firas?
Yes, we see you.
Yes.
Perfect. So we're gonna go first over kind of quick introduction on native valve infective endocarditis. Then we'll talk about prosthetic valve endocarditis in particular. So it's very common disease, as you know. It's affecting approximately 50,000 new cases every year in the US, with predilection for patients with the pre-existing structural heart disease, prosthetic valves, devices, IVDU, older population, and immunosuppressed. Mitral valve usually affected more than aortic valve, and nowadays staph probably a little bit more than strep viridans, and it carries high mortality, approximately 30% in 1 year. Now, there has been paradigm shift over the past several years. We are seeing more and more of infective endocarditis in older population, where it used to be so many years ago, I would say 4 years ago or so, more affecting more younger population. Also, almost 40% or more of infective endocarditis have no known cardiac disease, and approximately 20 to 30% have prosthetic valve or with or without intracardiac devices. Those patients with prosthetic valve endocarditis, they can have infection shortly after the implantation of the prosthetic valve in the first 2 months. And that's usually related to lack of endothelialization of the sewing ring, the sutures, and this will facilitate the organism to adhere and attack the kind of the host protein, the fibronectin and fibrinogen, and that will facilitate invasion in the kind of perivalvular area and creating an abscess and so forth. We can have also late infection after 1 year post-op, and that's similar to the community-acquired infection in native valve endocarditis as well. As I mentioned earlier, its epidemiology is 20% of the more or less of all cases of endocarditis currently related to prosthetic valve endocarditis. And unlike native valve endocarditis, aortic and mitral sites are affected equally in prosthetic valve endocarditis. Now, the question is, does the type of valve matters? The answer is yes and no. So if we look at the bioprosthetic aortic valve, for example, it doesn't matter if you have SAVR or TAVR. They both have the same incidence of the prosthetic valve endocarditis, but there's higher frequency of bioprosthetic valve endocarditis compared to mechanical valve endocarditis. And when we look at the TAVI group in particular, we notice that the median time of infection usually more or less is 5 months, and there's no significant difference between self-expanding and balloon expandable valve in terms of incidence of infection. Now, the risk factors for TAVI endocarditis that's divided into 2 factors. Patient's factor, we know that male patients affected more than female. Patients who had chronic renal failure, pulmonary disease, cirrhosis, previous endocarditis at much higher risk of developing recurrent endocarditis or developing endocarditis in general. There's also procedural factors. Those patients, you put a TAVI and you end up with a leaky valve. They are at higher incidence, paravalvular leak, and higher incidence of endocarditis. Patients with low valve implantation at higher risk. Patient who had complication during the hospital or transapical access. All of this carries higher risk for TAVI-related endocarditis. In terms of microbiology, what kind of pathogens we are dealing with? Initially, in the shortly after implantation, it's usually Staph aureus and coagulase negative staph, and sometimes we have gram negative as well, and Candida species. These are kind of the common nosocomial pathogens that are responsible for the infection. And beyond 1 year, we get Streptococcus and Enterococcus as well, in addition to staph and coagulase negative staph as well. We can also have culture negative endocarditis anytime. As far as TAVI, It's generally speaking, it's similar to surgical prosthetic valve, with the only difference is higher incidence enterococci in patients, in TAVI group patients. When we look at the prosthetic valve endocarditis pathology of the surgically implanted valve, the perivalvular invasion and dissemination through the perivalvular tissue there, resulting in dehiscence and paravalvular, and leakage or regurgitation. This is account for almost 40% of the cases. And occasionally you have more extensive necrosis and invasion there and causing myocardial abscess in 15%, I would say 10 to 15% of the cases. So this is, for example, a patient we saw, you can see here a patient with mechanical mitral valve and mechanical aortic valve. And you can easily spot that this valve is not normal and there's rocking motion there suggestive of dehiscence. And of course, you expect significant leakage here. Moreover, you can also notice echolucent space here, suggestive probably abscess formation with invasion of the aortic valve here, and some movement in the left ventricular outflow tract, which turn out to be endocarditis as well. Of course, you expect to see severe regurgitation where the dehisced valve is. This is an example of a perivalvular invasion and dehiscence with abscess. Occasionally also, the infection in the aortic valve itself can extend to the annulus and cause pericarditis, or can extend to the membranous interventricular septum and affect the conductive tissue, creating heart block. We see this not uncommon. And also in surgically placed valve as well, we see sometimes large vegetation affecting these valves, creating obstruction or incompetence. Like this patient, for example, these are one of our patients who presented with a fever post biprosthetic valve implantation several months later. And you can see large vegetation here, creating regurgitation and obstruction as well. As far as TAVI-related endocarditis, most of the information we have are inferred from imaging. Okay, and the echo usually shows vegetation or perivalvular complication, and the invasive complication for self-expanding valve and balloon expandable valve are similar. They're not that different. Vegetations, however, are more common on the self-expanding valve stents, where it's more common on the leaflet of balloon expandable valve. And we have to remember, in TAVI population, there's always 20% chance that the mitral valve can be infected, and there's almost a 20% chance that you may have perivalvular extension, creating abscess or subsequently pseudoaneurysm, even fistulas we've seen. This is a patient also came to our hospital with persistent fever several months after TAVI implantation. This is Edwards Sapien valve. The transthoracic echocardiogram was negative. We could not see anything, but this transesophageal echocardiogram, you can spot the vegetation easily attached to the leaflet in both 3D and 2D imaging. Now, clinical manifestation and complication of prosthetic valve endocarditis, essentially similar to the native endocarditis. Same symptoms. We're not going to go through the symptoms. Everyone knows the symptoms here. There's higher frequency of new or changing murmur or heart failure in patients with prosthetic valve endocarditis than native valve endocarditis. We have to consider endocarditis in this subset of patients with prosthetic valve when you have bacteremia or even persistent symptoms, non-specific symptoms without bacteremia. If you have just persistent and non-specific symptoms that doesn't go away, which are new in nature, you have to have high clinical suspicion for these patients, especially if the inflammatory markers are elevated. If you have, of course, new prostatic valve dysfunction, unexplained stroke or emboli, this will raise your suspicion for endocarditis. We all use modified Duke criteria, and we are not going to go over it. We know that we usually utilize this in the back of our mind whenever we deal with these patients, 2 major criteria or 1 major and 3 minor criteria. And we are all aware of the major criteria and minor criteria for diagnosis of infective valve endocarditis, and it's similar. However, we need to remember that for prostatic valve endocarditis, the detection by transthoracic echocardiogram, when we talk about one of the major criteria is a transthoracic echocardiogram or TEE, the sensitivity of transthoracic echocardiogram to detect vegetation or complication is at most around 50%. We have to remember that always. It's like 17 to 45%. For TEE, we can increase this from 80 to 100% sensitivity. 30 to 40% of the cases of prostatic valve endocarditis have no vegetation, but local complication like abscess or the hyst valve. So we have to remember that as well. This diagram illustrates our approach for these kind of patients when we suspect prostatic valve endocarditis. We get usually transthoracic followed by TEE most of the times. And if we don't see anything and our suspicion is still high, even with the negative TEE, it's recommended to repeat a transesophageal echocardiogram in 5 to 7 days. If it is negative and our suspicion is still there, then we have to go for different diagnostic modalities like CT or FDG studies. This is the diagram or illustration taken from European society guidelines for approach patients with suspicion for infective valve endocarditis, similar to what I showed you, but here they emphasize on the fact that for patients with prostatic valve endocarditis, we cannot stop. Always repeat the TEE if suspicion is still there, and consider cardiac CT and FDG. And this is part of the guidelines as well. So the diagnostic tools for prostatic valve endocarditis, we know blood culture, we always do that, echocardiography, and additional imaging tools. Blood cultures is positive in more than 90% of prostatic valve endocarditis without prior antibiotic therapy. Of course, we have to obtain 3 sets of blood cultures. Now we have to remember there are culture negative endocarditis, especially if there's fastidious organism. But there are right now the next generation sequencing and fluorescence technique, hybridization technique are emerging to increase the diagnostic capability for pathogen detection. Echocardiography, of course, is the tool to initially start with. Transthoracic echocardiogram is the initial study we usually do for several reasons, evaluate the function, the leaky valves, but we cannot stop there. TEE is the study of choice for detection of vegetation and complication for these patients with prostatic valve endocarditis. It has higher sensitivity, as I showed you earlier. And then we have to remember that the negative predictive value of modified Duke criteria, including complete echocardiography, is still low. I think it's approximately 65% in one of the case series. We have to repeat echocardiography, TEE, if suspicion is still there. This is one series, actually, they found that we can increase the diagnostic capability from suspicion of endocarditis to definitive endocarditis by 40% when we repeat a second TEE, if the suspicion is still there. There was no additional value for a third TEE. There are several challenges in diagnosis, in the diagnosis of TAVI-related endocarditis. The sensitivity is limited due to artifact and shadowing. Those of us who always do the TEE, we know that we sometimes face this problem with shadowing artifact, and we have to get different angles, different views to get over the shadow artifact. And if you chase it, well, you can increase the sensitivity, but you cannot just go to the mid-esophageal view and blinded with the shadow artifact and not see anything. You said that I don't see it. We have to go lower esophageal, upper, and different angles, try our best to overcome this limitation. Nonetheless, sometimes it is what it is, and we are just blinded and we with the shadow artifact, and we just can't see it. Echo failed to detect endocarditis in 15% of the patients in one of the case series, and we had to resolve to other diagnostic modality like PET or CT. So the echo rule in infective endocarditis, essentially early assessment to establish diagnosis, detect complication, evaluate the impact, hemodynamic impact, intraoperative, whether pre-pump or post-pump, to verify successful repair, and monitor during the therapy, antibiotic therapy, to see if there are complications during the therapy, and after therapy to get a new baseline for valve function and morphology as well. These are the essential three criteria, the three important pillars that we need to report in these patients. They make sure we have a correct diagnosis: location, size, number, morphology. Is there complication, abscesses or not, aneurysm, dehiscence? Is there a hemodynamic effect? What it is? These are the kind of the pillar of the good echo report in infective valve endocarditis. One of the patients we saw recently, 65-year-old female with previous mitral regurgitation, treated with percutaneous mitral valve repair using edge-to-edge clip technique, presented with fever and positive blood culture. Echocardiography was negative. We did not see anything, but sure enough, you can see here, there is vegetation attached to the clip itself. So the transthoracic, as I said, it has its own limitations. This is another patient we saw, 70-year-old man with persistent fever and positive blood culture. There was mitral regurgitation, transthoracic, but we could not define the anatomy very well. So this is the beauty of 3D echocardiography. You can see the perforation, where it is located, the hemodynamic effect, and this is where I love 3D echocardiography. This is the same patient actually. You can see huge, wide open mitral regurgitation through the perforated mitral valve leaflet. This 39-year-old patient with the bioprosthetic valve, you can see thickening here and eccolucent space, suggestive of probably an abscess, with communication through the LVOT with evidence of dehiscence with severe aortic regurgitation. So what if we cannot see with transthoracic or transesophageal echocardiogram? CT is the next to go to tool, and Dr. Muad will discuss this in detail in multimodality imaging. It will help us assess the complication, perivalvular extension. It has sometimes higher diagnostic accuracy in some situation, in some cases. I can show you just one image. This is the cine image. You can see thickened valve leaflet, vegetation, hypoattenuated mass here, and you can see low attenuation tissue here, suggestive of probably abscess formation and pseudo aneurysm here. FDG also, it has its own role, and Dr. Maad will discuss this also in detail. It can help us differentiate infectious from inflammation sometimes. This is a case where the TEE did not show endocarditis, but clinical suspicion is high, and you can see hot area here in the FDG study, and subsequently the patient have pseudoaneurysm. So, in summary, echocardiography is essential for initial cardiac assessment, but has its own limitation, as I mentioned before. TEE is preferred for detecting prostatic valve endocarditis, have higher sensitivity. Repeat echocardiography is essential if your suspicion is still high, and if you do not make a diagnosis then, but your suspicion is still high, do not stop there. Use other modalities. And remember, modified Duke criteria along with echo, it has low negative predictive value, and that's why we follow certain approach. Thank you so much.
Thank you, Dr. Mohammed Khalil. Really a comprehensive talk that covered major aspects on evaluation of prostatic valve endocarditis by echo. So we'll move to our next speaker, and then we'll have the questions and discussions after the talks. So as you heard, we have Dr. Maad al-Mallah, who's a consultant cardiologist from Methodist Hospital in Houston, and he's the head of the cardiac PET at the same hospital, and he's also the president of the American Society of Nuclear Medicine, and he's an excellent speaker. I have attended his talks before when he was in the region, and it's our pleasure to have him talk to us about multimodality imaging for device-related infections.
Thank you, Dr. Juwaidia, and thanks Firas and Emirates Cardiac Society for the opportunity to present to you today. And let me put up my slides. So I hope you see my slides well. Okay, so I'm tasked to talk about CT and FDG PET for endocarditis, and we just heard a lot about the diagnostic value of echocardiography and the clinical value of different imaging modalities, especially among those patients where we have different suspicion level. So what I would like to start with first, and I don't have any disclosures related to this stuff. So I would start with this. Echo is always the first step, and most often you don't need to go to the additional imaging modalities. But as we just heard, there are few patients where echo is not the last test, and I'll show you who are these patients and how can you utilize CT and the FDG PET in a more complementary way to what you have learned from echocardiography, and in which patient, because it may not be for every patient too. So first of all, most of these cases come to CT not with the suspicion of endocarditis. They could be coming for coronary assessment among patients who have already been diagnosed by echocardiography. Rarely it is an unsuspected kind of diagnosis that we make. One technical problem about CT kind of is a moving image. The temporal resolution is not as high as echocardiography. So if it is a very small vegetation that you clearly see on echo, you may potentially miss it on the lower temporal resolution systems. There are some systems that have higher temporal resolution, and they allow you to have good accuracy and be able to see that kind of lesion there. But as you just heard from Dr. Mohammed, really the role of CT is in endocarditis is to look for the complications. And most of these are the mechanical complications. So we are not really primarily looking for the vegetations, because echo is great for this, the temporal resolution is great. We are looking mostly for complications. Now, in terms of diagnosis of endocarditis, CT versus TEE sensitivity is 97% if we are using TEE as a gold standard, and specificity is 88%, and very high positive and negative predictive value. If we take it against operative findings among those that go to the operating room, sensitivity is even higher, and the positive predictive value is high. And then for size, vegetation, and mobility, it is accurate, but again, we could be underestimating, and a very small mobile structure we may not see very well. So to put it together, CT has a higher spatial resolution, give you volumetric assessment. In the era of COVID, it requires less PPE, so we were using it more often, especially among patients who suspected COVID, or if the patient has esophageal pathology, and if we are looking for other pathologies. Obviously, TE has the best temporal resolution, give you the flow assessment, especially with color Doppler, and it is preferred among patients with renal failure or contrast allergy, especially ICU patients that are very sick that you cannot transfer out. In terms of endocarditis, for leaflet perforation, TE has an edge, but we can see it also with CT. Invasive complications, this is where CT is better. And for prosthetic valve endocarditis, this is CT. For TE, both of them are good. For pannus, thrombus, calcification, CT is going to be better for these. And also for looking for coronary assessment and extracardiac findings, this is where CT is good. Here's one example where you have an aneurysm or a fistula that is connecting the VSD kind of related to the endocarditis. Here you have a pseudoaneurysm and adhesions of the valve there. And here's another case where you have another pseudoaneurysm, so another big time complication, and it is usually clearly seen on CT. So two of them there. We also can see, for example, an aorta to LA fistula, as you see here, and it's easily deposited here. We can see it very well. We can look, for example, for patients again with pseudoaneurysms. These are kind of very highly suspicious of endocarditis, especially when you see this hypolucency there. Now, the biggest question that comes to us often, is this infective still? Is this an abscess? Is this at this time infective, or we are dealing with mechanical complication? And that might have some implications for the timing of surgery if the patient is stable and obviously not decompensated. And that's why we use FDG PET for that. Looking at, for example, endocarditis, looking at prosthetic valves, we are able to see the metallic valves. With echocardiography, you may not be able to see these very well because of all the shadowing that you get. So sometimes smaller vegetations can be seen, and we can potentially differentiate a vegetation from the pannus from the thrombus or vegetation by looking at the Hansel unit. Obviously, it's not a 1 to 100% sure. And in this case, there are a ton of pseudoaneurysm around the valve, so making the suspicion that this is actually a vegetation much, much higher. We can also look for mechanical valves. You can see here another area of the leaflet motion section. So that tells you if the valve is having gradients and the leaf motions are they restricted. We are also seeing a lot of bioprosthetic valves. And if you look at these, not working well, but we look at these and actually look for the thrombus or vegetation. And obviously vegetation will look very close to a thrombus because it's an infected thrombus. So that might be one way to look at it. So where is TEE, where is CT? Obviously, there's complementary information. This is a nice study where they looked at 75 patients. Both of them had both tests, CT and TEE. And the studies where most of them actually were positive on both of them. But the discrepant studies, the TEE positive but CT negative, had most of them small vegetations. So CT can miss a small vegetation. again, but in terms of what TEE can miss, this is very nicely also shown here. It's paravalvular abscesses and mechanical complications. So valve perforation was missed on 3 cases. Paravalvular abscesses were not seen on 6 TEs, and intracardiac fistula was not seen on 1. So I like this one because it tells you if you are suspecting a small vegetation, don't go for CT because you can easily miss it. TEE would be your test of choice. If you are thinking of mechanical complications, abscesses, fistulas, then CT might have an edge over TEE for these patients. And again, looking here, you can see all these abscesses. So prosthetic valve endocarditis, 100% sensitive and very important for detection of this disease. We just heard about the TAVR valves. These patients are also challenging. This is one actually of one of my patients who had the TAVR valve, and she had an indication for a CT after the valve. And you can see the valve is nice and clean, and this is still imaged, but you can see nothing there. Few weeks later, she come back with E. coli bacteremia, and we could not rush her to TEE, but now you can see all this filling here. And then she ended up with positive cultures and decompensated and unfortunately passed away. You can see the amount of abscess and endocarditis that's noted within the valve. Most likely what happened is that she had either embolization of this or like complete thrombosis of the valve plus infection. So we cannot be sure, obviously, if this is a vegetation, but usually a vegetation is an affected thrombus, a lot of fibrin material. With CT, we can also gather more information of some tissues that are within the imaging field of view. So if you have an image of the kidney and there's this kidney infarct or a splenic infarct or even an aortic aneurysm, then you are able to be more certain that this is a endocarditis. And finally, pre-op assessment for coronaries. This is where most cases that I see coming with endocarditis, nobody wants to cath and get these patients and put a catheter next to the left coronary when you see this vegetation going up and down. And what we see is that CT has an excellent sensitivity in these patients. They are usually challenging because they have higher sensitivity, higher heart rate. So our sensitivity is pretty good. But again, it's a lot of the time that the heart rate is, we are unable to control the heart rate. That might be a challenge for these patients. So this is the summary of CT. This is why we do CT and endocarditis. So again, mostly to look for the local complications, as I said, the abscesses, the fistulas, and the number one reason why these patients are coming for CT is that they are going for surgery and they want us to assess their coronaries. Now, when do I use PET for this? So many of these hypodensities that we see on CT that I just showed you, especially post-surgical and others, may be infected but may not be infected. And you know that in terms, CT is just going to show you hypodensity. It's not going to tell you for sure that this is an infection. So what we utilize is that we utilize fluorodeoxyglucose. And fluorodeoxyglucose is just glucose, but it is labeled with F18. And it will go to highly metabolic cells and they will utilize it for their metabolism. So bacteria will take it, normal myocardium will take it, as well as the infection cells like the white blood cells will take it. So when we utilize that, what we see is that there is significant uptake in that area. And we will go through some of the nuances here. So when we give FTG, it goes inside the cell and gets stuck there. So we end up being able to image it and see it very well. And this is why we do the FTG imaging for these patients. So, but before that, I just want to warn you that to be able to achieve that, remember that the myocytes are also going to take FTG. And what you want to be sure that when you give FTG for these patients, they are sure that the myocytes are blocked from taking the FTG, so you are able to see the infectious cells and the white blood cells very well. And that's why we go ahead and utilize this protocol, which includes no carbohydrate diet the day before or even 24 hours, fasting for more than 12 hours, and sometimes we keep them heparin before the test, and then we image them. So that's kind of our protocol, and you can see here when I use this protocol, I can suppress the myocardium very well, but when I don't use this protocol, the myocardium will uptake and make it very difficult for me to look at the aortic valve and mitral valve. This may not be as difficult if you're looking outside the myocardium, but if you are looking for aortic valve and mitral valve, especially abscesses, you need to utilize this protocol. And this is what we look for. What we are looking for is intense focal uptake. So usually it's something that's very diffuse and general, becomes a little bit more concerning for inflammation. This is also very focal here. You see it more intense in one area compared to the others. But this one is probably very suspicious also too, because it is very focal and it's around the valve. And you can see here also another area where it is extremely focal, very high, intense uptake and no uptake in the myocardium. Sometimes if there is a graft attached to the valve, we see infection around the graft, and that's also another concerning thing. Here you find also, and again, a focal, intense FTG uptake is very concerning. This is one of my patients where we did CT and we saw this echolucency. Echo was read as normal, but the patient had surgical valve and he was having on and off fever. So the suspicion was pretty high. So they went ahead and did the did FTG PET after a transthoracic echo. And on CT initially with contrast, you see this hypodense area. And then when we give FTG now, I'm pretty sure this is a highly intense uptake. Same area, very intense, another smaller one there. And this is like almost, I'm pretty sure that there is something going on, most likely endocarditis in this patient. This is another patient with same thing. And if you're looking at PET alone images, this is how it looks. Can use it for TAVR valves too. So that's also another area that can be used for. And it could be also around the annular area, or it could be along the aortic part too, as you see here. So the bigger question is, like, I always get these questions in terms of which patient should go for FTG PET. Obviously, if your suspicion is high and you're sure, but if you're not sure, but the native valves are very problematic for reasons we don't fully understand. We do not see uptake in the valve itself. But if there is an abscess, then you may see it. So technically, if it is positive, you are sure it's positive. If it is negative, then it is unlikely to be, your negative predictive value, it is not that high. So this is a patient with vegetation, clearly nothing lighting up there. So clearly endocarditis on a native valve, but the FTG PET is completely normal. Now, if there was abscess, then we could have seen it. But since there is no abscess, then this becomes very concerning. So sometimes I get asked, can you do FTG PET for me for this native valve? And what I would say, if it is positive, yes, you make your diagnosis. A negative FTG PET in a native valve does not rule out endocarditis. So I just want to repeat that to emphasize it to everyone who's listening. A negative FTG PET on a native valve does not rule out endocarditis. You will need to do more testing for these patients, and TE would be your preference for this. So what are the limitations of FTG PET? It could be false positive, and about 15%. Obviously, I have to, as we are gaining more experience, we're getting less of these false positives, and you need to prepare very well the patient. You can also see FTG uptake on the glue material that they use in surgery, so that make it also more difficult. There are prosthetic thrombosis. Sometimes thrombosis might give you a little bit of FTG uptake, and when timing after surgery. And this is an area which was highly debated, but I think the guidelines currently say if you're going to do it, you wait 90 days. Now, sometimes again, I'm asked whether I should do it like early on. And if it is normal, then it is reassuring. So here, the patient already had prosthetic valve surgery, and we are coming in to look for the valve. Same thing if they had a pacemaker implanted, and they want to see if there is infection. If I see FTG PET, this could be just from the procedure that they had already. If it is no FTG uptake, then I'm pretty confident that this is less likely to be FTG, if there is no FTG uptake, then I'm confident that there is no endocarditis. If there is uptake early after surgery, it could be just inflammation. And here's like some example of inflammation. Inflammation is usually low uptake and could be related to the bioglue or the aortic graft that you see here. Again, endocarditis is focal intense uptake. It is not this mild diffuse uptake. So I just want to again emphasize that, because sometimes I get some reports where they call it endocarditis when you get this mild diffuse uptake. Mild diffuse uptake is not endocarditis. The other thing I want to highlight, you need to look at the non-attenuation corrected and the attenuation corrected. If the FTG uptake looks worse or significant only on the attenuation corrected, this is most likely not real. You can see here there's minimal, but it becomes more. But the real one, it's actually present on both. So it's very important to look at that. Again, there is a whole spectrum between inflammation and infection, and may be difficult sometimes to ascertain and also in the middle. But again, the pattern you're looking for, focal, heterogeneous, and intense. Focal, heterogeneous, and intense. The diffuse and homogeneous is not endocarditis and more likely related to inflammation. So how do we utilize it all together? I mean, there are also some areas in the heart that usually uptake FTG, so you need to be aware of them, like the right atrium itself. So that's brown fat. That's also a normal variant. Sometimes lipomatous hypertrophy of the interatrial septum. If there's significant, then this can have FTG uptake. So something very important, so you're not calling infection there. Again, this is like an area where when I see something, I would like to look at it on the non-attenuating corrected, because here's something that is showing on the attenuation correction images, but not on the non-attenuation. So this may be related to this device artifact. So whenever you have so much metal, this is the time you need to look at both the attenuation corrected and the non-attenuation corrected before you make a definite diagnosis. And you can also look for complications, like, for example, this patient in the lungs and other organs. So again, I want to re-hammer this point because this is one of the points of confusion as we get there. Native valve endocarditis, low sensitivity, high specificity. If it is positive, you're pretty sure. If it is negative, you need to go on and do more testing. For prosthetic valves, excellent sensitivity and specificity. So you are kind of sure of that, but you have to do it correctly to be able to have good results and be sure that there are not artifacts. We also look for complications, like, for example, this patient had discitis, and in about 60% of them, we find about some extracardiac findings. About 15% of them help us make up the diagnosis of endocarditis in these patients. The beauty of FTG PET is that it can supplement what you are unable to see very well with echocardiography, or CT, for example. So we look for pacemaker infections, for lead infections, and LVADs. I want to finish up with that. So this is a case where you see a device implanted. You see very, again, intense, heterogeneous, and focal. If it is diffuse, and you need to ask when was this device implanted. If it was implanted less than 3 months, then this could be inflammation. But again, inflammation is low uptake. If it is not low uptake, then I will be very concerned about infection, even if it's new. And you can see here the amount of FTG uptake around the infection. And now, since this modality became available, we are doing more and more of these cases when for the pocket or for the leads that we look at. And the sensitivity for the cardiac implantable devices is very high, 87% and 94%. And as you very well know, this may be very challenging to diagnose by echo and even by CT because we have a lot of blooming artifact from the device leads and metal that you see on the CT. And again, to hammer it out, I'm showing these numbers multiple times because I don't want to be giving you the wrong impression, but this is a meta-analysis. So FTG PET for native valves, low sensitivity, high specificity. If it is negative, then it is not good. I mean, you need more testing. And if it's positive, then you make a diagnosis. Prosthetic valves, good accuracy, and devices, good accuracy, almost like 72% sensitivity in the meta-analysis and 83% with the specificity. But again, as the technology improved, that includes some historical data, and the data now is much better with the different meta-analysis. And finally, with LVAD infections, and this is, I know that you guys are starting to put some of these in the United Arab Emirates. And as you know, some of the causes of death of these patients are either bleeding, thrombosis, or infection. So the infection in LVAD could happen at multiple sites. It could happen in the driveline, it could happen at the entry point, could happen in the device itself, or in the outflow cannula. So with PET, we are able to look at these very well and assess these. So either the pump, the driveline, the entry point, and the outflow track. So let's look at some examples. The entry point is very easy to see. You just need to look at it, look at the patient, and you're able to see it. The bigger question that always comes to us, is this limited to here or this is extended more? And as you see in this patient, unfortunately, it's not limited to the entry point because you see it all lighting up all the way to the device there. So this is a patient who had positive endocarditis step. Another patient who had multiple points. So he had an FTG uptake on the device, he has FTG uptake on the prosthetic valve, and he has FTG uptake in the outflow cannula. So multiple sites of infection. But again, heterogeneous and very intense uptake all through. And this is one of our patients where you see the outflow infection, again, heterogeneous outflow, and this is very concerning for infection in these patients. We also look at the entry point, and you can see here the impact of attenuation correction, but again, very important to see it that it's present on both of them. And finally, this is someone who had it on the entry point, but also on the device itself. Again, for these, you need to look at the attenuation correction and the non-attenuation corrected. We know the more extensive the infection, the worse it is and the worse the outcome. So if there is no infection, great outcome. If it is only the driveline, not central, then it's good. If it is more on the pump or in the outflow track, then this is very concerning, and usually there is very high mortality. And this is another series that just came out and clearly showing the same thing. More intense infection, worse outcome in these patients. So you not only can diagnose these patients, but also prognostically identify them. So where is it in the guidelines? Unfortunately, it was not until recently that this is becoming more of aware. And as you see, most of these papers are less than 10 years old. And Europe is probably more advanced in this field in specific compared to the United States. The first time that it was ever mentioned in the USA was on the valvular guidelines, where it clearly says that if you have a possible endocarditis, obviously after your echo and your echo is still not certain, then FTG PET is a class 2A to identify that. If you are looking for paravalvular abscesses, this is where cardiac CT is going to be the main tool for you. And if you're looking to establish the diagnosis, then TE would be your way. And so again, to summarize it, if you have infection or still suspicious, you're still in the probable range, but you're looking to establish the diagnosis, your TEE. If you're looking for extracardiac or like in the vicinity complications, including paravalvular abscess, fistulas, CT would be your way. And if it is still possible, then you can look for FTG PET to help guide you there. And the Europeans, you've already seen this from before. Again, in the probable or in the possible, then FTG PET is going to be your tool. And in the definite, if you have suspicion of septic emboli, then you can consider FTG PET in other areas of the body. And if there is local extension and you're not sure if it's an abscess or not. So to summarize it up, for prostatic valve endocarditis, FTG PET, CT, and TE are all helpful. Diagnosis usually suspected by transthoracic, confirmed by TE if you can, but CT and FTG PET are going to be a good tool to help you with the local extension or for the early detection of extracardiac infectious source or emboli. For devices, FTG PET is going to be your main tool to look for local infection. CT may add, but we always get some sort of CT with PET CT, and the leads also are going to be it will be very helpful to assess them with FTG PET. And finally, for LVAD, this is probably the tool where FTG PET has a huge role compared to transesophageal echo and others, given the amount of blooming artifact and all the device-related artifact, but also the complications that will need further assessment for infection. So thank you very much for having me. I know we'll have some discussion, and then later on I'll show you a case on how we managed.
Thank you so much, Muad. That was fantastic. Between you and Mohammed, we had a comprehensive overview of the roles of different modalities and how these modalities come into play. I would like to invite all the presenters and Dr. Juwairiya as a panelist. I will start with Dr. Juwairiya and ask a few questions until we get some questions from the audience. Dr. Juwairiya, oftentimes we get a request to repeat a TEE in somebody with prostatic valve endocarditis, and the original or the initial TEE was negative. What is your checklist? How do you decide when is this appropriate? When do you repeat it? What are you looking for, and so on?
So I think this was mentioned clearly in Dr. Khalil's presentation. So if you still have the suspicion and you did not get the diagnosis from the initial images, then it's reasonable to repeat it after 5 days to a week. Of course, so what's your suspicion, right? So this is the question. How are you going to suspect it? So generally, if you have someone with a prostatic valve and you have on and off fever, whether or not you have bacteremia, that's sometimes difficult to achieve, especially that there's a lot of use of off-label antibiotics in the community. So sometimes you don't have bacteremia, but you have the symptoms. You have on and off fever, you have unexplained symptoms, you might have heart blocks or even changes in ECG that are unexplained. If someone did not have first-degree AV block before and now that's there, then that's raises your suspicion that maybe something is going on there and you need to look further. If you have signs of embolic phenomena, So renal, GI, even unexplained abdominal pain can be a sign of embolic phenomena, and maybe someone did not look into that. So it's going to end up being very clinically related, right? You have to have the clinical suspicions. Once you have it, then you need to repeat it. And I think one of the things that I liked about Dr. Khalil's presentation is he said, yes, so you do the transthoracic, you do the TEE, you do the second TEE, but don't really go to the third TEE. Because by that time you really, you did everything you can, and the likelihood that you're going to catch something on the third TEE is very, very low.
That's correct. Thank you, Dr. Juwaria. So it's been looked at, and the additional value of the third TEE for better diagnosis was not much. So if you're still suspicious, you can do the FDG as Dr. Muad mentioned as number one, and CT sometimes can be helpful, but usually CT will look for complications rather than diagnosis. But you can also do that.
Thank you both. Dr. Muad, a question from the audience. What protocol, or what is any specific protocol or image acquisition tips when you do CT for endocarditis?
So for endocarditis, first of all, you need to know your patient and you need to know your state. Obviously, of course, the patient most of the time and doing retrospective. So even if the patient is having high heart rate, and this is most commonly in this case, the fever infection and all of that, we need to give them really try to gather good image quality. We need to be able to capture it in systole. Plus, if there is a bulge, you want to know if it's expanding in systole and diastole. So it's going to end up being there. But on the other end, the timing is really helpful. I would also recommend in non-contrast, even though non-contrast study in the beginning, to forecast the patient or whatever, because sometimes you could and usually I try to gather a quick low dose immediately after. So sometimes if there is a pseudo aneurysm or something, it may end up filling late or something. So not knowing obviously what you're going to see, but if you know the patient, you've known their TE, you know what to look for. Again, if you're looking for fistula, it would be very helpful too, especially if it is suspected, if there is color on echo that's going from aorta to LA, that might require the retrospective to be able to see it very well. So knowing your patient, obviously if you have two CT machines in your hospital, I would do the one that has a better coverage and the temporal resolution, the better temporal resolution, because again, you need to be able to see it. Coronaries in these cases could be a hit and miss in the acute phase, but these are the main tips. So I usually start with a non-contrast retrospective and may or may not do a delayed image, but the non-contrast, you can even do it with less than 1 millisievert just to see where is calcium when you look at it. But you need to get a full set of assessment in systole and diastole to be able to make sure that you're not missing. Again, these are not just looking for a vegetation or not. Usually the ones that come to CT are looking for, we call them Goombas. I mean, there is something big there.
Fair enough. This is very, very useful. Any questions from the panel to the speakers?
I actually have a question. So I think it can go for both speakers, and also for you, Faras, you can give an input on that. So, I mean, it's usually it makes sense when the patient presents like a book, right? Fever, bacteremia, and these things. But sometimes we get on echo, just screening echo, and you get something that looks like vegetation. And then now you're trying to establish if this is infective endocarditis or not. And then becomes complicated, especially with what you said, Dr. Muad, that the PET will not tell you that this is vegetation or not, especially in a native valve. So what's your approach in something like this? Like, what do you do? Do you screen for everything and then see what you get? Do you do another imaging? Do you take the patient for surgery?
Right.
What would you do?
That's true. I can start, and Dr. Mu'adh can also comment. Again, it's we see this on occasions when we read echoes that there are things that suspicious. Again, we have to remember that it's all clinical diagnosis, and I mentioned that the modified Duke criteria, but with a caveat that it has low negative predictive value in patients with prosthetic valve endocarditis. So it performs better in patients with native endocarditis, but for prosthetic valve, when you just go to the modified Duke criteria, it may not perform as good. So personally speaking, when I face with this situation, I usually first look at the clinical picture, look at the kind of inflammatory markers, just discuss with the referring physician, and if there's suspicion, I tell them just get blood cultures, the patient has symptoms or not, and if everything doesn't fit or there's we just monitor that. I'll give you another example. We see a lot of things when we do TEEs on the leads. Sometimes is it like fibrin? Is it thrombi? Is it vegetation? What will you do with that? We see this quite a bit. Now, as Dr. Mu'adh said, that we can do sometimes FDGs, which, however, we have to remember that without pocket infection, the sensitivity of FDG in these kind of lead, the infection is not as high. I don't know what the sensitivity is, 60% or 80. It's good, but it's not that great. So I think for me personally, I just go back and look at the patient as a whole and make a decision. I don't know, Dr. Mu'adh?
Again, it's going to boil down to your suspicion of pre-test suspicion. If you're just reading an echo and there is just a mobile structure, I find it very helpful to go back and look at the previous echo, especially if it's a prosthetic valve. Could be just like a loose suture or something there, and that might be very helpful for you to figure that part out. If there is more suspicion, if it's a native valve, to me, FTG PET is going to be a hit and miss. If you get it, it's going to be okay, but if you don't get it, that's more concerning. For other kind of tools, I think it's going to be very helpful to sometimes CT can help you if this is more thinking more of a mechanical complication. But if it's just something moving, again, it could be even missed on CT because of the temporal resolution. So sometimes going to TE. But if you're thinking of a mechanical complication, abscess, some sort of weird color flow, then this is where CT can help you. If you're thinking of FTG PET, I think for the lead itself, we have good sensitivity there now, especially with the newer PET scanners. And if you follow the structure, the preparation very well, you will be able to detect the lead infection. Obviously, unless it's very tiny, but now the significant lead infections will be usually picked up very well by FTG PET there. So the main concern is going to be what is your pretest likelihood to this compared with prior echoes. And if this is something new, patient is febrile, then you may potentially go to the route of either TE, or CT, or FTG PET, depending on exactly what your question is. If it's just a mobile structure that you're looking for, TE probably would be your best. If you're looking more for a local extension complication, something around the valve, then CT would be your best tool. And if you're looking for, there is something, but I don't know if it's active, infectious, or remnant from before then, this is where PET could potentially help you.
Mu'adh, any role for tagged white cell scan in workup of endocarditis? It is often mentioned, but it didn't come up in this discussion.
So I had actually a slide on it. I took it out. So tagged white blood cell scan actually is a good tool, and usually it is more specific than FDG PET, but less sensitive. So what people have been using is that what they do is that in some centers, like what they do, they start with FDG PET. If there is uptake and they're not sure if this uptake is real or not, or if it's inflammation or not, then they do a tagged white blood cell scan. And this is going to be more useful, this approach, among those patients where there is mild inflammation. Another important factor for FDG PET is if the patient has already been on antibiotic therapy. So we are a referral center. We get the patient who has been in another hospital for 15 days getting antibiotics, and now they're coming to us. So in these, I have to lower my threshold to call something. Most likely, if it was true endocarditis, it's not going to completely go away. But now a milder uptake, it's not going to be as intense compared to somebody who's antibiotic naive. So the duration of antibiotic therapy is going to be very helpful. And like, for example, recently I was taking care of a patient who had multiple TAVR infections, and he has very mild FDG uptake. But the nice thing is that this patient had another FDG PET few weeks, like 6 months before that, and there was nothing. But digging more, now I have something with mild uptake and the history, nothing, no uptake. This patient was on 2 weeks of antibiotics when I did the second PET scan, so most likely this is real. So we told them continue antibiotics and do it, and we did a third FDG PET, and now it's like almost gone. So it's a comparison with the old studies is going to be very helpful on echo, but also sometimes if you have other studies available, it's going to make a big difference for these patients.
There's another question in the chat box about the role of is there any role of PET FDG in patients with clips, mitral and tricuspid valve clips? Has this been studied, looked into, published?
I mean, as long as it's metal, so it's theoretically, I have not had actually, I may have had one case. But the case that comes to my mind now, I had a left atrial appendage, actually, clip, not a mitral clip, a left atrial appendage surgical clip, and it was extremely intensive. I mean, this was like very intense uptake. So anything metal, obviously, the more metal we put in the heart, the more the chance that these get infected. And FDG PET is going to be very helpful for these patients. So as long as it's metal, then you should be able to see it. If it's native, then like may not be able to see it. So metal is, yeah, I mean, left atrial appendage, theoretically mitral clip, you can see it. I don't have like too many of these cases, just one case of infection in the mitral valve.
Maad, can I ask you a question about lead endocarditis? How often do you utilize FDG in your practice for patients who are suspected to have lead infection? You know, when you see something moving in the TEE where you are not sure and patient has questionable bacterium, how often do you reach for FDG? And what's your experience in terms of sensitivity for?
Just in the past, like what, 2 years, I would say, we've done like 200 plus cases of these. And like many of these, like went to the, like the case I just showed you for like the valve, the aortic valve, went to OR, and it was exactly 2 abscesses around the valve. We have published on graft infections, so on the vascular, and we had like 28 patients that we published on that had graft infection correlation with intra-op cultures and biopsies from the site of the graft infection. So these are areas where I have diagnostic accuracy data. Now, if we go for non-diagnostic accuracy data, I mean, looking for leads, we had few cases of like isolated lead infection, and somebody saw something on echo and it was suspicious because the patient is febrile and all of that. And it becomes more concerning when we do the FTG PET because we covered the lung. And in that specific case, like one of our fellows published actually, we found that there was a significant lung uptake on a specific area concerning for abscess. So when you combine it now with that thing that you see on the lead, now you're getting more clues that this is a lung infection. Obviously, you can always play that this is pneumonia and this is like started in the lung and went to the lead. But when you put it all together, it becomes more helpful. So on the lead side, I like to look very well at the lungs, and FTG PET is going to be very helpful for these patients. Just like pure isolated, I remember like very few cases, and most of the cases were like pocket infection with some lead, but isolated lead, few of them. I remember one of them, we showed that there was something in the lung, which made us very concerned about endocarditis in that case.
Okay, wonderful, thank you.
It's been a terrific discussion. Thank you all. It's now time to show some cases from different institutions and see how these modalities can put into play in routine clinical practice. And for this purpose, I'm going to introduce my colleague, Dr. Shadi Higazi, who's a cardiologist from the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. He has a strong interest in cardiac imaging, particularly cardiac CT and echo, and he will be sharing a case that he has taken care of in our practice. Shadi. So we'll come back to Dr. Shadi. He's having some technical difficulties. Perhaps I can ask Dr. Mu'ath to present his case to stay on time, and we'll come back when Dr. Shadi is ready.
Okay, so let's quickly go through this case, which is a patient with LVAD who came in with a fever. So this is a 72-year-old ischemic cardiomyopathy, had an HVAD on destination therapy by VICD, chronic pseudomonas driveline infection, and had multiple incision and drainage, and came into the hospital with low-grade fever, fatigue, and loss of appetite. So now the question is this still just a driveline infection, or this is becoming worse? And obviously the source of fever may be from somewhere else, but this could be getting worse. So there are no significant alarms on the device interrogation, and this patient had both PET and CT, so I selected this case to show you that. So in terms of the procedure, what we did is that for this patient specifically, we asked him, because he's sick and others, we wanted to use prolonged fasting for 18 hours. We injected FTG 10 millicuries and waited 60 minutes and then imaged the patient. So this patient had the CT the day before, and you can see it's very difficult really because of all the beam hardening artifact that you see and the blooming to really if you can tell if there is infection or not. It is becoming very difficult with these. And even when you utilize a newer technology with beam hardening reduction artifact and blooming artifact reduction algorithms, it becomes a little bit challenging really to be able to get this information there. So what can we do here? So again, it's becoming, you can see the outflow track looks okay and the prior CT. But again, we cannot tell if this is a tissue outside or next to it is infected, inflamed, or anything. So this is kind of one of the limitations of cardiac CT in these patients. So if there's a mechanical problem in the LVAD, that's going to be very helpful by CT. If there is like a thrombus or kinked or occluded, this is where the device, where CT would be helpful in LVAD. But if there is infection, you could still have infection in the outflow tract, even if the CT looks okay. So we did undergo this, and obviously we couldn't suppress the myocardium. So this has failed even after 12 hours of fasting. So But since we are mostly looking for the non-device and the patient was sick, so we're like the device itself, we can look around it, but you can see at the point of junction, we cannot tell for sure. But what you can see, what was very concerning was this is a drive line, this is going to the inflow, and this is the outflow track. You can see extremely intense uptake through this. So we have the we have the drive line, the outflow, and the device. And we don't see much around the device, but mostly around the inflow. And you can see it here again, the inflow, multiple lymph nodes in the chest. This is the device, the drive line. And you can see here the outflow has significant uptake. So the pacemaker, so when they ask for this, they want us to look at pacemaker, to look at every device. So pacemaker has no uptake around it. So clearly multiple areas of concern. And this is a case where we were very much concerned that there's an outflow tract infection we reported SUVs of 6.8. And there is also the drive line, which is very concerning even for abscess on the CT. So this case kind of really tell you how we look for the extent of infection, but also at the same time look for the we can follow it up in these patients and shows you also what each modality can bring to the table. CT is more for mechanical complications, kinking, what is the lead, what is the outflow or the inflow, there are alarms, high pressure. But for infection, there is no better than FDG PET in these patients because it will help you assess all of these throughout. So we're imaging primarily the inflammatory cells, so they take it and they go inside, it goes inside, and they're very helpful. So FDG PET is a useful technique in identifying LVAD infection, determining the site and the pattern and also the extent. And this is very helpful for guiding patient management and has patient implications. Thank you very much.
Thank you, Mav. This is a great case. I'd like to invite the panelists one more time, and I have a question for you. How is patient prep for inflammation infection imaging is different from patient prep for viability, which is a more commonly used application of PET FDG?
Yeah, so for viability, you want the myocyte to take FDG. For infection, you want the myocyte not to take FDG. So they are like completely opposite preparation. So for viability, we want to give the patient insulin. So we want to give them as much as we give them insulin. So when we inject FDG, the patient is ready to, that FDG goes to all these hibernating myocytes. With inflammation, I want to give them as much as they like free fatty acid. So myocytes like free fatty acid. If free fatty acid is available, they will just go and fight for it, and they will get the fat. So for a condition like inflammation, infection, we want them to have little sugar. That's why we fast them. And we want them to have as much as we can free fatty acid. But on the other end, for viability, we want to give them as much as we can radio-labeled sugar, and we have insulin on board. So insulin will make the myocytes like FDG or like sugar, and then they will just go ahead and consume it, and then we can detect the viable myocytes. So think of them as exactly the extreme opposites in different situations.
You know, part of the issue why, at least maybe Mohammed will agree with me, the difficulty we encounter with utilization of PET for inflammation and infection imaging is the difficulty of getting patients to comply with the dietary restrictions and the concern about getting a non-diagnostic study. In a busy lab like yours, Muad, how often do you run into equivocal or non-diagnostic studies because of poor prep alone?
So you're asking all the relevant questions. I know you're asking them for the audience, and this is very helpful. So this is the real threat here, obviously. I mean, you don't want to have non-diagnostic studies or cases that are falsely positive. So it is a normal physiologic uptake, and then you end up calling it infection because you think that it is not. So the way we do it, actually, two things. If for inflammation, like sarcoid or any inflammation in the heart, then I would like to make sure that the patient follow the diet. So we moved actually for outpatient, we moved completely to 48-day preparation. And we published recently our experience. We were the first to describe actually the utility of beta-hydroxybutyrate in these patients. And what we found that if you we do measure beta-hydroxybutyrate at the time of the test, and if the patient followed the diet instructions and if the patient had good response, then the beta-hydroxybutyrate is going to be above 0.4. And if it is above 0.4, all our cases actually were positive, were like normal, not normal, I mean, were diagnostic. There are after us two groups published their literature, Michigan and Penn, and they found very similar cutoffs. So what I would say is that the way you prepare them, there is some variability. So in Cleveland Clinic, Ohio, now they started doing actually IV free fatty acids. So for inpatient, they give the patient, they fast them and they give them IV free fatty acid preparation. This is like for patients like similar to those who are in the ICU, and then wait some time and go ahead and do it. There are some preparations that come like with the kids that are allergic to carbohydrates, so preparation. So people actually, like in Mayo Clinic, they give them like something like that. I heard that it's not gonna be your best tasty drink that you will have, but it's just like you just drink that and then you go ahead and have that. But irrespective, so from our end, what we are noticing is that the patient follows the diet, we are able to achieve diagnostic accuracy above 90% where we have myocardial suppression. So we are we set up, and we've done now more than 1,000 cases in a couple of years. So it's not a small number, and our nurses call them every day. Not to say that we do not get non-diagnostic studies, but yeah, I mean, for inpatient, I never get them injected unless they're now beta-hydroxy for the past 2 years since we got our internal results, unless their beta-hydroxy is 0.4 and high. And since then, I've not had the worst difficult patients were actually the inpatients, because especially many of their IV injections are in D5 water, especially mineral. I mean, something I come to know after doing many of these cases, if the patient is mineral, the standard for pharmacies is to put it in D5 water. So we went down the list. What are the cardiac medications that are in D5 water? Because there is a patient who followed everything, but he was on chronic minoron, and we just could not get it done until somebody alerted us that minoron was in D5 water. So something always to keep in mind and learn on this. Now for infection, I'm a little bit less stringent for that. It depends on what I'm looking for. If it's aortic valve, mitral valve, I usually want to be well suppressed. But if it is a pacemaker device, LVAD, usually the contact with the myocardium is much less. So I usually just like fast these patients, and they are usually sick. So I don't want to torture, give them very hard time while doing this. So usually we get easy on them. And even if there is uptake, you just saw this case. I mean, there is uptake, but there is enough. Like if it's only at the rim where the myocardium is touching the LVAD, that's fine. But if there is usually the amount of infection in these cases, way, way more. And it's a lot. The bulk of them that I've seen are in the drive line and in the outflow track. And the drive line or outflow track are a little bit far from the myocardium. You also get a lot for EVAR, TVAR, all kind of like dialysis fistulas, abdominal aortic aneurysm, all these devices that we get for these. And for these, I'm also fasting for 12 hours. So again, only for mitral and aortic valve, if there's a concern about an abscess, because the annular ring has some myocytes in it, and I really want it to be suppressed. Other than that, for infection, I'm less stringent, but again, this is mostly because the structures I'm concerned about are a little bit far away from my sites.
Great. Thank you so much. Dr. Juwairiya, if you have an inpatient and you have a scenario similar to the one that Dr. Muad described, and if you don't have access to PET facilities or capabilities, what has been your approach to these situations?
You mean like the case that he presented with the LVAD?
Correct.
Yeah.
Or if you have a prosthetic valve endocarditis, but you don't have access to PET, what is your go-to test in that case, in that situation?
So, I mean, for prosthetic valve, generally, like you start with the transthoracic and then transesophageal echo, and usually you get the answer by then, or you get a suspicion. Like you might not get a complete answer, but you get suspicion that there's something around the device, there's something around the valve, or there might be something behind the valve. So if you don't have access to FDG, I mean, of course, FDG is very helpful, but if you do not have access, plain CT can be helpful, especially for just mechanical complications, the presence of aneurysm. You can see para-aortic abscess. So that can be helpful. I think that probably that, or you can send the patient to a facility where they have the FDG to get the diagnosis. But generally by that, like most of the time by TE, we can get the diagnosis. I think Dr. Khalil will agree with me. It's very important, as Dr. Khalil mentioned, is not to rely on just standard images. So you need to try to take off-axis views. You need to go transgastric sometimes. I find for aortic valve, transgastric views are very helpful, also for the mitral valve prosthetic endocarditis, because you can really go away from the glare from the prosthetic valve, and you can see really representative images of what's happening with the patient.
Excellent. Thank you so much. Dr. Shadi, do you think we can get back to your case?
You can hear me, Professor, well?
Yes.
Yeah, you can go to the case screen. I can see.
Okay.
So we'll go to the first slide. This patient, again, just fast history, he was 65 years old male who was known to be hypertensive, hyperlipidemic, and with history of Pentel operation with aortic valve replacement since 2 years duration. He presented to us with confusion and left side weakness. So we did CT protocol and including the CT brain and CT head and neck CT angio, and was negative for any large vessel occlusion. So on presentation, he has fever, 39.7 with elevated inflammatory parameters, including the white blood cells and CRP. And we sent his blood culture, which came positive for strepto oralis. And his ECG was not normal sinus rhythm at next to Tulfras. Sinus rhythm with first degree heart block on his presentation. So we put differential diagnosis, but our first suspicion in this patient, because he came with history of AVR and fever with raised inflammatory parameter, was prosthetic valve infective endocarditis. So we decided to use our different modalities to confirm this diagnosis, which usually we start with transthoracic echo. Next, Frost. So we did the transthoracic echocardiography, which was not so impressive and just showed that well-seated prosthetic valve with mild concentric LVH and didn't show any vegetation at this imaging modality. So we tried to see what was the second modality you can use, asking Dr. Khalil even if his transthoracic echo at this point is enough in the diagnosis of prosthetic valve endocarditis.
No, of course, as we said, this is carries very low sensitivity, so we need to proceed with TEE.
There you go, you got it.
Yeah, so this is what we think about. So we went to TEE, which showed it's the large equidense collections, which involving the aortic root and the aortomitral continuity. Even the type showed no regurg or stenosis, but there was highly suspicious of abscess versus maybe its collections or hematoma from the previous surgery. So we need another imaging modality to confirm this diagnosis. So what do you think, Dr. Muaz, what we can go for?
Obviously CT is going to be very helpful in these cases if you're looking for this hypolucency. And again, FTG PET would be a good tool to look for that. So I think all modalities are in play here. So whatever is available and local expertise in your place would be very helpful in your decision what to go for next.
So we decided to go for CT, as you show in the slide. It's just so irregular soft tissue thickening in the non-coronary leaflets, which give concern for being vegetation versus thrombus. So we are not sure about it. There was another paravertebral slides. I think next slide, Dr. Raz.
Next slide.
Yes. In the paravertebral region, there was crescentic soft tissue density, which showing enhancing thickened wall, which giving highly suspicion for paravalvular abscess. But till this moment, we are not sure it is abscess, thrombus. So we decided
I have to say, sorry to interrupt, but this CT to me is like calling for catastrophe here. First of all, the valve leaflet is very thick there, so you can see it. And the valve, I don't know how this was protocol, but looks like if there is looks like there might be significant AI and the valve leaflets are not closing at any time. And also all the thickening around the valve is very abnormal. So to me, this is an abscess until proven otherwise.
Yes.
You're pointing out to this area, Dr. Mah.
Yeah, but you also, if you go back on the reconstructed image, it's well seen there too. If you go to the next slide. Yeah, I mean here between 11 o'clock all the way to 6 p.m. I mean, on the other side, to the 6th side, like all of the structures, I mean, or if you like, you say between 11 and 1 and between 3 and 6. This is the word.
Thickens,
Yeah, so I mean, this is very concerning. I mean, to me, this is positive for endocarditis, and especially that the valve itself doesn't look calcified, but it's not closing, thickened.
And thickened, is enhancing look.
Yeah, so that's why we like to do a non-contrast specifically for these to look for calcification. Because if this valve is 10 years old, this could be degenerated. But if there are like not 10-year-old valve, then this is most likely endocarditis. But with the abscess around it, I mean, to me, if you're like hesitant, the patient is hiding for surgery, you don't want to because again, surgeons like to gather more information, and this is like a very extensive infection. I mean, so the surgeon, first of all, want to know where the extent of infection. So how far does it go in the LVOT? How far does it go up on the aorta? So that's going to be also another helpful information that you get from FTG PET, because most likely this will require a whole root reconstruction too there, in addition to the valve. So the LVOT, valve, and root reconstruction.
Do you think white blood cell scans have a role in this situation, 2 months?
Yeah, I mean, if you don't have access to FTG PET, they are more specific. But if they come back negative, then I wouldn't take them, because this is like, to me, this is endocarditis. I mean, so the sensitivity of white blood cells are less. And so it's, but I mean, they are a good tool, but FTG PET definitely more sensitive for this.
Okay. So
this is a situation where there was no access to PET on the inpatient side, and the patient was sent for SPECT tagged white cell scan instead.
Yes, it came with positive findings. There was increased uptake around the right paravalvular regions, which corresponding to the same area in the CTA. So it was really paravalvular abscess.
But as you can see, I mean, on the CT, it's catastrophe. You can see here it's minor uptake. So you can see the sensitivity issue by your eyes. I mean, you saw how bad the abscess was on the CT, and you see here, I mean, somebody can argue this is just mild uptake. So there is a sensitivity issue here clearly. But I mean, on the CT, this was like somebody who needs like intervention for some time.
So after that, what cells we take a decision in MDT meetings that we will go for conservative treatment with antibiotics for 6 weeks, and we'll follow him with inflammatory parameters. We inserted the ICC line and we give antibiotics. Then actually the patient lost the follow-up for 6 months. Then
Shadi, can I ask, what was the decision behind the conservative treatment? Was it uncertainty about the diagnosis, or more of an issue about surgical risk, redo, and all that stuff?
About the surgical risk, because we discussed in the meeting with the surgical, because it's the second time for him, and the patient had a history of stroke before in 2019. And there was highly suspicious of stroke this time also, so the risk was high as a surgical point of view. Yeah. So
there was no issue about this diagnosis that we're dealing with here.
No. We confirmed this. The CT was highly suggestive, and white blood cells was just confirming it. But the CT, as Dr. Maat said, is more sensitive for that and specific.
Can I just ask a couple of questions? So, I mean, how much AI was there on the echo? I missed that part.
The echo didn't see. I don't think you showed us the color flow on this.
Yeah. I mean, to me, if like, I don't think this patient is gonna get better. I mean, here you already have it also there. I mean.
In the echo, as I remember, there was no appreciated AR in it at this time.
Yeah, so that's good to know, because the CT, it looks like it was all protocoled in systole, so that's why you have the valve all open. So you don't get a diastolic frame of the aortic valve. But irrespective, I think, I don't think this patient is going to get better. Either it's going to be on maintenance therapy, but this is like a patient who is prone to develop like significant complications from that.
Yeah. Actually, he lost follow-up for 6 months, and he came again. Can you show the slide for us?
Sure.
So he showed again after 6 months, actually with again with dizziness and imbalance at this time, and we did CT brain back forward. At this time, we did MRI brain and showed there is acute infarction in the caudate nucleus with chronic left thalamic infarction. But at this time, the blood culture came negative, and still the CRB was high. So we again, yeah.
Did they rule out brain abscess? Because that's another concern here.
It was ruled out. Okay, so we did we repeated again the TE, and it showed there was a large echo free space in the aortic root and in the aortic mitral curtains, which are highly suggestive of aortic root abscess. Even compared to the previous TE, we saw that the echo density lesion before it changed. There is change in the density, and was suspicious there is a fistula between the aorta and the left atrium.
But how do you explain this? Sorry, go ahead, Mom.
No, I mean, you're getting almost a natural history of prosthetic.
Yeah.
I mean, like, this is how these come. So sometimes we capture them in the early phase. Now it's getting even to the pseudoaneurysm. I see it bulging out in systole, and it's like clearing up. So this is like fistulas.
Yeah. Yes. So after TE, do you like to stop here through my eyes, or do you like to continue?
No, go ahead.
So we did the cardiac CT And although it showed complete resolution of the echo, the nodal soft tissue density before, but it showed there's pseudoaneurysm, as you mentioned, regular.
But the soft tissue is not gone; it's there still.
It's still there.
Yeah,
It's still there.
yeah. It's like, yeah. So abscess pseudoaneurysm. So, yeah. I mean,
I
it's
think
unfortunate. I mean, if the patient is not surgical, unfortunately, we cannot offer him. I mean, there are certain things we can do and certain things which we cannot do. But since then, I think we already know the diagnosis. So, I mean, the management could be challenging, and we don't know all the factors that the treating team had to deal with when treating this patient. And again, I'm not in a position to kind of like comment on that, but from a diagnosis standpoint, this is like, yeah, we had some cases like that. You just put them on suppressive therapy for a long time and you hope for the best if there is no surgical option.
So, as a complete of what you said before, we did the PET scan and it was non-specific actually for this. The uptake was, it can come with inflammations, with infections, but mostly with the story scenarios coming with prosthetic valve endocarditis. So, because the patient was not.
How would you interpret this PET scan, Muad, in the setting of prolonged antibiotic therapy?
Yeah, I mean, there is FTG uptake in the lateral wall, and like usually it's a normal variant, but here it's very concerning. I mean, I wouldn't call it non-specific. I would like to see the SUVs. I would like to see but yeah, again, this is a challenge in the setting of prolonged antibiotic therapy that you might not be, your thresholds for lower there should be. But again, I would like, you have a CTA, so I would like to see that area of echolucency or hypodensity. It looks like it's uptaking FTG on the axial images. So to me, this is like highly suspicious. Like this is positive. The guy, I mean, first of all, our suspicion is pretty high. And the second thing is this FTG PET likely to be called positive. Yeah.
So you like to stop?
Dr. Shadi, you have 1 minute to conclude.
Yeah,
give us a wrap up on this case. We're running out of time.
We decided to continue on the antibiotics for 6 weeks, and with the infection disease consultation, we decided to continue amoxicillin suppression therapy for at least 12 months. Then we saw him in the clinic. After that, his general condition is improving. He has improvement in the, even LV function was a little depressed in the second time, so it's improved. So giving plan for him for repeating the TEE or CT scan in the next visit. Okay.
Excellent,
Thanks.
excellent.
Yeah,
Thank you.
interesting case, but unfortunately tough patient to deal with. And yeah, I mean, we always deal with these patients, and not like, but this case, like, yeah, if you don't have good operative option, unfortunately, you're limited in options. The only option to do is to prolonged long-term therapy. And I think from all the modalities that you have, it looks like the local expertise is in CT and you're getting good quality. And now that you're getting more into the mechanical complication area with pseudoaneurysm and maybe fistulas and others, if there is deconditioning, I would say CT might be, if he has good kidney function, I would say CT would be a better way to follow. We know it's infectious. So PET is not going to add much. I think now we are more concerned, is this pseudoaneurysm going to rupture? Is it going to cause a fistula to the LA? Is it going to cause anything? So transthoracic and CT would be a better way to kind of like follow him up.
Okay, it is 8:52 local time. This has been a really great discussion, terrific input from everybody. A great participation from the audience. I would like to thank each and every one of the esteemed members, Dr. Muad al-Mallad, Dr. Juwairiya al-Ali, Dr. Mohammed Khalil, and Dr. Shadi Higazi. And I would like to thank the audience for their participation. And until we meet in the next session of the multimodality rounds of imaging working group, I would like to thank you all, and please stay well. Thank you so much. Have a good night, everyone.
Thank you and good night.
Thank you and good night,
Thank you.
everyone.
Night.
Pleasure.